Bismillahirrahmanirrahim. I'm Fawad Ali, Assistant Professor, Department of Pharmacy, Department of Science and Technology. Welcome to the course Pharmaceutical Clinical Pharmacy 4. Today, the topic of our discussion is fungal infection of skin. This is the second part of the fungal infection of the skin. In last lecture, we discussed the cutaneous and superficial mycosis. Outlines. In today's lecture, we will discuss the following contents one by one. Like in previous lecture, we discussed the superficial and cutaneous mycosis. In this lecture, we will discuss the subcutaneous mycosis, sporotrichosis, case studies, and treatment. So, lecture outcomes after watching and listening, the student will know about the subcutaneous mycosis, types, and treatment. Subcutaneous mycosis. These are caused by fungus that grow in soil and on vegetations and are introduced in subcutaneous tissues through trauma. These are caused by the fungus that grow in the soil and the vegetation and are introduced in subcutaneous tissues through trauma. So, sporotrichosis, sporo is the example of the subcutaneous is the sporotrichosis. Is a case study. Like OM, a 62-year-old man has had a painless, slowly enlarging ulcer on his left hand for the past 4 months. He is an avid gardener but can identify no antecedent local trauma. The primary lesions begin as a red papule that slowly enlarge and then ulcerate. At the same time that the ulcer developed, OM also noted painless red nodules that spread proximally up his arms. He denies any chill, fever, weight loss, or cough. The ulcer has the ulcer has enlarged despite daily application of povidone iodine ointment and 2 weeks of cefixime treatment. On physical examination, OM is febrile. A 1.5 centimeter square ulcer is present on the dorsum of the left hand. Extending proximally from the ulcer is a papillable cord and multiple non-tenders. Erythematous nodules distributed linearly up the forearm, the elbow, and the axilla. A culture of this ulcer obtained 4 weeks ago is now growing sporotrex secondly. So this is a case study. A patient as a 60-year-old man is a gardener. He has enlarging ulcer on left arm. The primary lesion began as a red papule and slowly enlarged and then ulcerated. What is the recommended therapy for the OM? What is the recommended therapy for the OM? Like sporotrichosis is also known as a rose gardener disease. It is known as a rose gardener disease and is a subacute or chronic infection caused by the saprophytic dimorphic fungus. It is Sporothyrex secundii. Sporothyrex secundii is the dimorphic fungi found in the soil and on many plants. Infection is usually secondary to the inoculation into the skin from thorn or a sharp plantar uh, metal, plant metal. The, the characteristic infection involve supporting subcutaneous nodules that progress proximally along the lymphatic channels. Lymphocutaneous sporotrichosis. Rarely, extracutaneous disease may occur and usually involve the lungs, bones, or joint. So, the treatment of the heat treatment, like in 1930 and 1940, local heat was applied to a mild plague or a lymphocutaneous disease. Like germination ratio of this dimorphic fungus actually can be described by increased temperature. This is the heat applied to a very small plague or cutaneous disease. Germination ratio of this dimorphic fungus actually can be caused by increased temperature. Heat therapy 1 hour per day for 3 months is effective in 90% of the patient with a plague with a mild disease. Like heat therapy is 1 hour per day for 3 months effective in the 9. So heat treatment could be particularly useful in pregnant patients when the pharmacotherapy may be contraindicated. So these are the like this is the heat treatment was applied to very mild plague. The germination of the rate of the dimorphic fungus can be decreased by the increased temperature. 1 hour per day for 3 months is effective in 90% patient with plagues. Heat treatment could be particularly useful in the pregnant patient when the pharmacotherapy may be contraindicated. So medication therapy like etraconazole. Etraconazole cure rate for the sporotrichosis cutaneous and lymphocutaneous disease are greater than 90%. Like the medication therapy for this is the cure rate for the sporotrichosis cutaneous and the lymphocutaneous disease are greater than 90% with the etraconazole. 90% etraconazole 100 to 200 milligram for 3 to 6 months. Amphotericin B. A patient with extracutaneous disease who are unable to tolerate the higher etraconazole dosage or whose disease continue to progress should be treated with amphotericin B or a liquid-based amphotericin product. This is a medication like etraconazole is very effective against the sporotrichosis. The patient with extracutaneous disease who are able to tolerate the higher etraconazole dose or whose disease continue to progress should be treated with the lymphotericin B products. An adult dosing of 0.1 to 1 milligram per day per kg IV is suggested. Terfenabine. Terfenabine has good in vitro activity against the second Chi and has useful use clinically. Adverse reaction include GI distress like nausea, dyspepsia, diarrhea, skin rashes, and weight gain. A dose of 200 milligram or 500 milligram BID for 3 months for lymphocutaneous disease appear clinically equivalent to the etraconazole. So this is like 250 milligram or 5 milligram for 3 months for lymphocutaneous disease appear clinically equivalent to the etraconazole. So therefore, in the case of lymphocutaneous disease, etraconazole 100 milligram per day for a minimum of 3 months is treatment of choice. Like specifically in the case of lymphocutaneous, then if the significant improvement not absorbed in first 6 weeks, The itraconazole should be increased to 200 mg per day and continued for 6 months or until both the ulcer and lymphatics, lymphangitis has resolved. Most patients will respond to the dosage, but an occasional patient may require dosage of 3 to 400 per milligram per day. Sorry. So, Casey, what instruction should OM receive for taking his itraconazole dosage? Like counseling. The peak concentration of itraconazole capsules are ninefold higher when the drug is taken with food, like 0.18 mcg per ml with food versus 0.02 mcg per in the ml per in the fasting subject. High carbohydrate meal decreases the absorption of the itraconazole. So these are some precautionary measurement for before indicating or prescribing the itraconazole. High lipid content meal increases the itraconazole absorption. So therefore, OM could be instructed to have these to his itraconazole capsule with his high fat content meal of the day. So itraconazole solution can be substituted to improve the absorption. Itraconazole solution is a cyclodextrin formulation that has 55% availability in the fat patient, that is increase in the fasting patient. So viability of this formulation is not affected by the level of the gastric acidity. So itragonisole's oral solution is cyclodextrin formulation that has in the fat patient, that is this increase in the fasting people patient. Viability of this formulation is not affected by the level of gastric acidity. One should take his itraconazole solution on an empty stomach twice a day if this formulation is selected. Like if, because there is no not affect this solution is not affected by the gastric acidity. So OM should take atraconazole or any empty stomach twice a day is selected. How could instruction for taking itraconazole capsule be modified if OM were aclohydro achlorhydric as a result of medication or AIDS gastropathy? Like itraconazole capsule as with the ketoconazole require an acidic environment for the dissolution and absorption. Thus, the patient who are achlorhydric, either as a result of medication, surgery, or underlying disease, for example, AIDS, gastropathic, may not absorb itraconazole capsule adequately. So, the administration of ketoconazole and itraconazole with a low pH liquid, that is for example 8 to 6, 8 to 16 fluid ounce of the carbonated cola, beverages, or the orange juice. Improve absorption in the healthy patients who are achlorhydric or are on H2 blockers. So voriconazole does not require an acidic environment for adequate for absorption like itraconazole or ketoconazole, but voriconazole should administer 1 hour before and after meal, as high fat meals may reduce the voriconazole serum concentration. But it can be replaced in cases of the achlorhydric patient, like they require acidic environment for the dissolution. So voriconazole do not require any acidic environment for their adequate oral absorption. In contrast, posaconazole plasma levels are fourfold higher than higher after administration with the food or high fat nutrition supplements. Should azole serum concentration be monitored for an assessment of the efficacy? Serum ketoconazole, itraconazole, and voriconazole concentration less than 0.5 mcg per ml have been associated with the treatment failure. Therapeutic drug monitoring is justified in patients in whom therapy is failing. Similarly, posaconazole serum concentration less than 0.7 per ml have been associated with the treatment failure. So these are the references taken from the fungal infection. Rhoda Campbell. Thank you so much.